Hello PG aspirants, welcome back to the PYQ series and the channel Microbiology Simplified. I'm your guide and mentor Dr. Amit Kumar Singh, and I'm again here with a very important topic of microbiology which is asked very frequently in various PG examination, Corynebacterium diphtheria. So without wasting any time, let's start with the video. PYQ number 11, Corynebacterium diphtheria. So let's start with this MCQ. It is about a 6-year-old child presented to OPD with complaints of fever and sore throat. On examination, a well-defined whitish grey exudative substance was found adhered to the oropharynx that bleeds when an attempt was made to remove it. And there is also considerable cervical edema. And there is no history of childhood immunization as informed by the parents, and a microscopic examination of sore throat stain by Albert Stein showed the image given below. So what is the diagnosis? So many information given in this question, and to answer this question correctly you need to know that whatever information given in the question belongs to which particular disease and the bacteria. Okay, so we'll point out the information right now. That is, first the age of the patient, second the presenting symptom is of fever and sore throat. Examination revealed a whitish grey exudate adhered to the oropharynx and it bleeds when an attempt was made to remove it. Okay, and there is also cervical edema and no history of childhood immunization. Okay, and the throat swab is stained by using Albert stain, which show this characteristic structure of the bacteria, in which we can see dark stained greenish color of this present at the end, and then light green color of the bacteria. So what is the diagnosis? So the answer to this question is diphtheria, and I will just go into the detail of the disease, then I'll come back to the question again and tell you why it is only diphtheria and not any other disease. Okay, so the diphtheria, if you see the morphologically, it is gram positive pleomorphic rod. Okay, and it has got club at the end. That means it will look like this, gram positive pleomorphic rod with club at end, and these clubs are basically the polymetaphosphate granules, and these granules are also known as volutin granules or Babes Ernst granules, or also known as metachromatic granules. Okay, and these granules are stained by, or this bacteria is stained by, commonly by Albert's stain, which is a special stain for staining Corynebacterium diphtheria. Apart from Albert stain, we can also use Nizer's stains, Ponder stains, and also this metachromatic granules or this polymetaphosphate granules can be stained by methylene blue, and these rods are arranged either in pairs or in palisades. What does it mean, palisade? That means they are arranged in rack, like the fence, okay, on the boundaries, and it may be arranged in small groups. Okay, and these small groups may be arranged either at an angle to each other like this. So this will give this small group a particular arrangement called as cuneiform arrangement or Chinese letter arrangement. Okay, cuneiform arrangement or Chinese letter arrangement. Okay, so this is about the morphological feature of Corynebacterium diphtheria. The toxin which is responsible for the disease is heat labile protein or polypeptide, and the strain which is commonly used for production of toxin is Park Williams 8 strain of Corynebacterium, which is commonly used for production of toxin. And the exotoxin, this protein toxin which is produced, its production depend upon the presence of a lysogenic beta phage, which is known as Corynebacterium. Okay, and this Corynebacterium carries a gene which is responsible for toxin production known as tox gene, and this, if the strain contains this gene, it is called as tox plus strain. And this Corynebacterium is responsible for lysogenic conversion of tox minus Corynebacterium diphtheria into tox plus phenotypes. What is this? This tox minus means those who are non-toxigenic. So this non-toxigenic can be converted into toxigenic by this corynebacterium. And also iron plays a very important role in toxin production. That means the concentration of the iron should be optimal for the production of the toxin. So if the concentration is 1.1 milligram per liter, then it is leads to optimal production of toxin. However, if it is increased to 0.5 milligram per liter, then it will inhibit the production of toxin. So the concentration of toxin iron is very important in production of the toxin. And this toxin is consist of two subunits, A and B. A is the active and B is the binding subunit. And the receptor for the binding is heparin binding epidermal growth factor like precursor and CD9 receptor. Okay, and the mechanism of action is how it will act. It will lead to ADP ribosylation of elongation factor 2, which is responsible for protein synthesis, and thus it inhibits protein synthesis. Okay, it inhibits protein synthesis and thus lead to cell death. Okay, there is another toxin which is produced by Pseudomonas known as exotoxin A, produced by Pseudomonas aeruginosa, which acts in a similar manner. And there are certain other toxin produced by different bacteria which inhibits protein synthesis, but then the mechanism is different, and that bacteria are Shigella dysentery, which produces Shiga toxin, and Shiga like toxin produced by STEC, that Shiga toxin producing E. coli. If you want to learn more detail about the toxin produced by various bacteria, you can go through that bacterial toxin video, which the link is given above in this video. So go through that if you want to know the detail about the toxin produced by the different bacteria, including Corynebacterium diphtheria. And how this disease pathogens occur. So this toxin get absorbed into the epithelium of the oropharynx and destroy the epithelium. Okay, and induces a superficial inflammatory response. And due to destruction of epithelium and this inflammatory response, this necrosed epithelium along with the fibrin exudate and this inflammatory cell like WBCs and RBCs and the organism which is responsible for this leads to formation of a grayish color pseudo membrane. And this pseudomembrane in case of respiratory diphtheria is commonly formed over tonsils, pharynx and larynx. So these are the common site of formation of pseudomembrane, or these are the common site of respiratory diphtheria. The pharyngeal one is the commonest. And any attempt to remove this pseudomembrane will tear the capillaries beneath it and leads to bleeding. So this pseudomembrane, when it is tried to remove, it will bleed. Okay, this is characteristic of the pseudomembrane formed in case of diphtheria. Along with this, there is enlargement of the regional lymph nodes and there is marked edema of the neck, that is the paratracheal area, and also there is airway distortion and giving it an appearance known as bull's neck appearance. Okay, bull's neck appearance, and this bull's neck appearance is further characterized by foul breath, foul smelling breath. Okay, thick speech, and stridorous breathing. Okay, so these are the characteristic of bull's neck seen in case of diphtheria. And also the commonest cause of death among adults and children is suffocation due to aspiration of membrane. Okay, suffocation due to aspiration of membrane is the commonest cause of death among adults and children. Okay, and the differential diagnosis of pseudomembrane seen over tonsil, the first one is Corynebacterium diphtheria, second one is streptococcal tonsillitis or pharyngitis. So how to differentiate between these two pseudomembrane? So in case of Corynebacterium diphtheria, as I told you, an attempt to remove the pseudomembrane will leads to bleeding. It will bleed. However, if the pseudomembrane formed in case of streptococcal pharyngitis or tonsillitis, if it is tried to removed, it will not bleed. So this is the main difference between these two pseudomembrane. Okay. Another DD for pseudomembrane over tonsil is infectious mononucleosis, which is caused by Epstein-Barr virus. And the characteristic of Epstein-Barr virus is presence of heterophile antibodies. Okay. And then Vincent angina, which is basically acute necrotizing ulcerative gingivitis, also known as trench mouth, which is commonly caused by Prevotella, Fusobacterium, and spirochetes such as Borrelia vincenti. And because of this reason, it is also known as Fusospiroketosis. Okay, Fusospiroketosis and candidiasis. Okay, oral thrush. Okay, so these are the DD of pseudomembrane over tonsils. Epidemiology, if you see, the only reservoir of this diphtheria is who? Humans. Okay, and the mode of transmission is airborne droplets. Okay, apart from this, direct contact with infected respiratory secretions or exudates. Okay, an incubation period is around 3 to 5 days, and it infects mainly unimmunized children and young adults, but it can also infect immunized individuals. Okay, but the disease is milder in them. Okay, milder in the later. Okay, And what are the diseases which we can see? Commonly we will see respiratory diphtheria, and the site of infection is most commonly, as I told you in the pathogenesis, is pharyngeal. And what we can see? The pseudomembrane. So you can see this pseudomembrane formed over the tonsil in this image. Okay. So this is the commonest site of respiratory diphtheria. And this clinical diagnosis is based on the constellation of three things. First is the sore throat. Second is pseudomembrane, which may be adherent to the tonsil as in this image, or to the pharynx or nasal membrane. Okay. And there is presence of low grade fever. So these three criteria can be used for clinical diagnosis of respiratory diphtheria. Cutaneous diphtheria, the characteristic lesion in cutaneous diphtheria, if you see in this image, is the punched out lesion. Punched out ulcerative lesion. And also we can see this necrotic slugging, and in this image you can see pseudomembrane. Okay, so necrotic slugging or pseudomembrane, and the characteristic lesion is punched out ulcerative lesion. Okay, and where it occur commonly? Commonly it will occur in this order. First common area is lower extremity, followed by upper extremity, then it involve head, and then trunk. Okay. And the complication which we can see in case of Corynebacterium diphtheria, the very common is asphyxia, and this is due to mechanical obstruction. And what is the reason for mechanical obstruction? Mechanical obstruction is because of pseudomembrane. And in which age group this will be common? This asphyxia or this mechanical obstruction is common in children. And why children? Because of narrow airway. And then acute circulatory failure. Post-diphtheritic paralysis, this is a very important complication which is seen in around 3rd to 4th week of infection. Okay, and initially this paralysis will be local to the pseudomembranous area, that is the soft palate and posterior pharyngeal wall, but later it may involve oculomotor nerve or ciliary nerve. Okay, so oculomotor paralysis, ciliary paralysis, soft palate paralysis, and posterior pharyngeal wall paralysis is commonly seen. Okay, and this toxemia, this toxin may damage the distant organs such as heart and lead to myocarditis. Okay, and this myocarditis is usually associated with arrhythmias and dilated cardiomyopathy. Apart from affecting heart, it may affect kidney and leads to tubular necrosis. Okay, and it may involve nerves and leads to demyelination. Okay, lab diagnosis. The transport medium which is used to transport the swab taken from the throat is semi solid amines medium, and this semi solid amines medium can also be used to transport the swab taken for Neisseria. Okay, and microscopy, as I already told you, that Albert Einstein will be done for Corynebacterium diphtheria, in which we can see the polymetaphosphate granules at the end. Okay, polymetaphosphate granules at the end, and these granules which is present at the end are called as polar bodies. Okay, polar bodies. And this polymetaphosphate granule, when it is stained with Loeffler's methylene blue, will take up bluish purple stain, and because of this reason, as it is stained with a bluish color stain and changed into a bluish purple color, so because of this reason it is known as metachromatic granules. Okay, and the culture medium which is used for cultivation, first this blood agar is used to cultivate to rule out what? The commonest differential diagnosis, that is streptococcus. So to rule out hemolytic streptococcus. Okay, and the medium which is used for growing Corynebacterium diphtheria is tellurite blood agar. And in this medium, this tellurite blood agar, this tellurite is basically potassium tellurite, and this potassium tellurite, this Corynebacterium diphtheria has a capability to reduce this potassium tellurite into metallic tellurium, and thus will change the color of the colony into black. So in this tellurite blood agar, this Corynebacterium diphtheria, the colony will appear black in color. The Stinsdale medium, this medium also contains the tellurite. Apart from tellurite, it contains cysteine and sodium thiosulfate. Okay, so this tellurite will reduce into metallic tellurium, as in this case of tellurite blood agar, and will give the colony a black color. And this cysteine and this sodium thiosulfate will act as an H2S indicator system, and as this Corynebacterium diphtheria will produce H2S, so this colony will be surrounded by a brown halo, and this brown halo is because of this H2S production, and this black center is because of this metallic tellurium. So in case of Tinsdale medium or modified Tinsdale medium, the colony will be black with a brown halo. Now another medium, Loeffler serum slope. This Loeffler serum slope is a nutritionally inadequate medium, as it only contains serum and no blood. So the other flora of the which is present in the mouth, the growth will slow down. The growth will slow down. Nutritionally inadequate medium. Okay, and what will happen, this Corynebacterium diphtheria will outgrow. Okay, this Corynebacterium diphtheria will outgrow them, and the growth can be seen within 6 to 8 hours. This is the advantage of Loeffler serum slope. So in this image, if you see, this is tellurite blood agar, and these are the black colonies, which is because of reduction of potassium tellurite into what? Metallic tellurium. Okay, can see here. This is tellurite blood agar, and this is Tinsdale medium. So if you see here, this colony is This colony is black center and surrounded by a brown halo. So this is the characteristic of Corynebacterium diphtheria in tin-stale medium. So tin-stale medium is a selective medium for Corynebacterium diphtheria. Now we have to demonstrate the toxicity for diagnosis. So the demonstration of toxicity is done by a method called as LX immunoprecipitation method. Okay, and what we will do, this is the strip of the antitoxin. So we will place a strip of antitoxin in a agar plate, and then we will streak the various test strain perpendicular to the antitoxin strip. Okay, so if you see in this first case, there is no formation of band like this. This is called as precipitin band. So as there is no formation of precipitin band, that means there is no reaction, there is no precipitation reaction occurs because of presence of antitoxin and toxin. So this is non-toxigenic. The second and third, if you see, you can see the precipitin band, and thus it indicates reaction between toxin and antitoxin. So these two are toxigenic Corynebacterium diphtheria. Again, this fourth one, again there is no formation of precipitin band. So this is again a non-toxigenic strain. Okay. So this is a very simple method to detect the toxigenic and non-toxigenic Corynebacterium diphtheria. The treatment of Corynebacterium diphtheria, the first treatment is antitoxin. If it is confirmed case of Corynebacterium diphtheria, we need to treat the patient with antitoxin to neutralize the toxic effect. For pharyngeal or laryngeal disease of duration less than 48 hours, the dose of antitoxin is 20,000 to 40,000. Okay. For nasopharyngeal diseases, it is from 40,000 to 80,000. And for extensive disease, it is from 80,000 to 1,20,000. For extensive disease of duration more than 3 days. And antibiotics which is usually given for the treatment of Corynebacterium diphtheria is penicillin. And in case of penicillin allergic patient, we can use erythromycin. However, the drug of choice is erythromycin. Okay. And the immunization, for immunization we use DTaP. What is DTaP? DTaP is basically consists of full level of diphtheria toxoid, then tetanus toxoid, and acellular pertussis vaccine. Okay, and it is usually recommended for children less than 6 years of age, and the schedule is 3 doses in first year of life, that is at 6, 10 and 14 weeks, and then one dose it at 15 to 18 months, and then one dose between 4 to 6 years. The booster of adolescent and adult, what we can give, instead of giving DTaP, we'll give TDAP. What is TDAP? TDAP is actually tetanus toxoid reserve dose of, or reduced dose of, better term is not reserve, it is better term is reduced dose of diphtheria toxoid and acellular pertussis. Okay, so this is the booster of adolescents, or for booster we use Tdap. For immunization we use DTaP. Remember this. For immunization DTaP, for booster Tdap. Okay. And then there was a test which was done earlier but now it is obsolete. So it is used to determine the susceptibility of individual to diphtheria. Okay. And what we will do in this test, we used to inject intradermally the diphtheria toxin. So in case of positive test, the skin become red and swollen because of absence of antibodies. Okay, and thus it indicates that the person is susceptible to diphtheria. And in case of negative test skin, there is no change, which indicates presence of antibodies, and thus it indicates immunity to diphtheria. But this test is no more performed now. So one more question which was asked on this topic is: a 4-year-old child present with fever and bull's neck. As shown in this image, you can see this bull's neck, enlarged neck. So what is the most likely diagnosis? So I told you in the pathogenesis that the bull's neck is basically because of the enlarged lymph nodes and edema of the paratracheal area. So this leads to formation of a feature or appearance called as bull's neck, which is characterized by foul smelling, thick speech and stridorous breathing. So answer to this question is diphtheria. Okay. Pseudomembrane covering over is seen over the tonsil in all except. So that means pseudomembranous tonsillitis is seen in all except. So as I told you in DD, the first one was the diphtheria. The second one was streptococcal tonsillitis. The difference between these two, that the second one, this does not bleed. Okay. And then the third one was infectious mononucleosis, more commonly called as faucial mononucleosis in case of involvement of pharynx. So this also is the DD. This Ludwig's angina, in the DD I told you about Vincent's angina. So what is the difference between these two? In Ludwig's angina, there is no involvement of pharynx. However, it will involve submental or submandibular region. Okay, but not the tonsil. So the answer to this question is Ludwig's angina. Positive sick test indicates, so positive sick test means the skin will become red and swollen and indicates absence of antibody. So what does it mean? It indicates susceptibility to diphtheria. Immunity to diphtheria means negative, no skin change. That means presence of antibody. That means immune to the disease. It does not indicate anything about carrier or hypersensitivity to diphtheria. So this is all about this topic, and I hope this video is going to be helpful for you to solve all the questions related to Corynebacterium diphtheria. Don't worry, this topic is made from Harrison and Mandell, including the textbook of microbiology like Anant Narayan. So don't worry, you have all the information which is required for your examination in this video. So don't worry, just go through it and definitely you will be able to answer all the questions. All the best. See you in the next video.